Sir, please start.
Okay. Hello everyone, I am Dr. Sarvana Krushna Raja, Cardiothoracic Surgery. I thank RRNX and Doc Tutorials for this fantastic discussion about Sabiston 22nd edition Cardiothoracic Surgery updates. So in this new book, you can able to appreciate a major update about coronary artery disease and CABG. And there are few topics, the new topics that has been added in this new edition book. They are pulmonary embolism, acute and chronic, and advances in ECMO, and regarding the heart and lung transplantation. So these are all the topics. These three topics has been newly added in this 22nd edition Sabiston book. And if you see, there are no any major updates in thoracic part, lung, chest wall, pleuro, mediastinum. And regarding the congenital heart disease and valvular heart disease, there are no much updates, and the previous content has been exactly copied in this new book. So major updates being coronary artery disease and CABG, pulmonary embolism, ECMO, heart and lung transplantation. So we can see one by one what are all the updates that has been given in this new edition book. Coming to the update one, about the PDA. So till now, no book has been given the name. That is inferior interventricular artery. As you all know, PDA usually it arises from the right coronary artery, runs in the posterior interventricular groove. It is also called as inferior interventricular artery for your understanding. And you know the percentage has been clearly given this year. So majority, it is right dominant because it is from right coronary artery. The percentage being 85 percentage. Okay. If it is a left dominant, in few individuals, 8 percentage arises from the left coronary artery. If it is said to be a co-dominant, that is in about 7 percentage, it arises from the both the right and left coronary artery. So this update is regarding the PDA. And coming to the pathophysiology of coronary artery disease. So it has been clearly given. So what is the pathophysiology behind the start of coronary artery disease? The main initial event being endothelial dysfunction, followed by nitric oxide imbalance that triggers the inflammation, then plaque formation that leads to ischemia, followed by myocardial infarction. The sequence of events is to be understood. So this can be asked for your examination. And the third update being the plaque events causing acute coronary syndrome. The most commonest plaque event causing ACS being the plaque rupture, followed by plaque erosion and calcified nodule. So these points has been updated in this new book, and this MI classification. So this MI classification has not been in Bailey or even in your Schwartz. So this has been updated in the new edition. Type 1 to type 5. So MI has been classified according to the fourth universal classification. The type 1 being a spontaneous coronary event, and type 2 being that's due to supply demand mismatch, and type 3 MI presented with sudden cardiac death, and type 4 being the MI during PCI, during angioplasty, some patients may develop MI. So that has been classified as type 4. And you know, CABG having a risk of perioperative MI. So any MI occurring during CABG has been classified as type 5. So this is one of the major update that has been given in your new book. And coming to the update 5. As you all know, the troponin plays a major role, the major biochemical marker in identifying the myocardial infarction. And this new edition has been clearly given as the troponin as the preferred biochemical biomarker for identification of MI, because it having high sensitivity and specificity for MI. And you know, CKMB is important, and myoglobin is also important, but this has been given as proven as not superior to troponins, and this two has not been recommended nowadays. And the important point regarding the fractional flow reserve. In the previous edition, only a definition has been given, but in this book, a clear-cut cutoff and the evidence of using the FFR during angioplasty has been given. So what is an FFR? It is nothing but the ratio of maximum blood flow in a stenotic coronary artery versus normal artery during coronary angiography. It can be measured with the pressure wire after adenosine-induced hyperemia, again for your MCQ. And the FFR is less than or equal to 0.80. It signifies the hemodynamically significant stenosis. So it indicates the revascularization in the form of either PCI or CABG may be needed. If there is higher FFR, it indicates less ischemia. So even though the stenosis appears angiographically, if the FFR is more than 0.8, intervention may not be needed. So that is the beauty of FFR. The FFR guided PCI reduces major adverse cardiac events. As I guess all know about what is PCI. PCI is nothing but percutaneous coronary intervention, is also called as coronary angioplasty. So the superiority of conventional angiogram versus FFR angiogram has been proven. And regarding the IVUS, again, this new edition has been given many points about IVUS. So cardiologists are nowadays using IVUS in and out for coronary stenting. So why it is important is nothing but the ultrasound guided monitoring of the intravascular lesion. It evaluates the vessel morphology, the lumen dimension, the plaque burden, and the morphology. And it is very, very useful in left main coronary artery disease, again for your MCQ. And there has been evidence that is showing the IVUS guided PCA reduces mortality and repeat revascularization. Sometimes the patient getting angioplasty may present with restenosis within a year or within a 2 year because of improper placement of the stent according to the lesion. By using the intra-IVUS during angiography, it avoids a repeat revascularization. And there has been many meta-analysis study also showed the superiority of IVUS. And coming to the next update regarding the coronary CT angiography. So what is the difference between the regular angiography and the coronary CT angiography? Because this is non-invasive and the high diagnostic accuracy is also there, right? And it is having a high negative predictive value, and it is an excellent investigation to rule out coronary artery disease in low or intermediate risk patients, right? Suppose a patient being 40 or 45 years, having dyslipidemia, patient having symptom on and off. So in such a scenario, because scenario-based questions has been asking recent days, in such scenario, if you people want to do a good investigations to rule out CAD means the investigations will be coronary CT angiography. And you can also able to note the few trials that has been given in your new edition book. The PROMISE Scott Hart ischemia trial. So these are evidence-based trial that's showing the superiority of CT coronary angiography. And this table has clearly shown the benefit of CABG. When to do CABG? A patient presenting with STEMI. STEMI is nothing but ST elevation MI. NSTEMI is non-ST elevation MI. Okay. So patient with STEMI, when PCI is not feasible, CABG will be the choice. The patient presenting with STEMI with the mechanical complications. So what are all the mechanical complications? After MI, ventral septal rupture, mitral regurgitation, free wall rupture, or ventricular aneurysm. So in those conditions, the CABG is superior because we need to do a bypass surgery and along with the mechanical complication correction. Okay. Then coming to the stable ischemic heart disease, the patient presented with LV dysfunction, again CABG will be superior. The patient is having a left main coronary artery disease, again CABG will be superior. And again the patient having a refractory angina despite medications, again CABG is having its own value in improving the symptoms. And this update this year regarding the history and the evolution of coronary artery surgery is beautifully given. So when the first invention started regarding the CABG, the Alexis Carroll, he's the one who developed the bypass innovation in canine model. And you also note the Wienerberg procedure. So Wienerberg, he's the one who anastomosed the lima to the one of the territory of the anterior myocardial vessel. LETA is also called as LEMA. LEMA is left internal mammary artery and LETA is left internal thoracic artery. So Wienerberg is the one who first designed the anastomosis of LETA to the territory of the lady. And you should know the Kolosov is the person who anastomosed LEMA to a lady. Okay, you also note the year it has been clearly given where that has been started. And Sabiston was the one who performs the first venous graft anastomosis from the aorta to the concerned coronary artery. So these are all the updates which you should know in this new edition book. And coming to the next update, so this table shows the superiority of CABG versus PCI. So a patient presenting with complex multivessel disease with the left main coronary artery disease, no other confusion, CABG will be superior. And the patient multivessel coronary artery disease with the diabetes and LV dysfunction, again CABG will be beneficial. And this is the recommendation of another class 2A. The patient having the previous CABG, again presenting with symptoms, say period of 15 years or 20 years, again CABG will be the best option. And DAPT adherence, what is DAPT? The double antiplatelet therapy adherence. Suppose the patient doesn't want to continue aspirin and cloplet. So if for PCI, the patient needs to continue double antiplatelet. So for CABG, it may not be needed. The patient can able to continue even a single antiplatelet that is sufficient, say aspirin. Okay. So in those conditions, even CABG will be superior. And in those conditions with in-stent stenosis, suppose the patient already had angioplasty or PCI with the stenosis in the stent. So in such conditions, again, restenting may not be feasible. So CABG will be always beneficial in in-stent stenosis of the coronary artery. Other indications for CABG is a patient presenting with repeated ventricular arrhythmias. So in such conditions, it is very difficult to put angioplasty. So in such conditions, it is always good to open the chest and do a bypass surgery by using the heart-lung machine. And as we discussed, the patient undergoing valve surgery for a mechanical complication or a patient presenting with the mitral stenosis incidentally found to have coronary artery disease, again, is on a single setup, we have to do a valve replacement and the bypass surgery. In such conditions, again, CABG will be helpful. And this update, you can able to see the importance of the radial artery. So radial artery in this Sabiston, it has been clearly shown when not to use the radial artery. Suppose the patient with the chronic kidney disease, we should try to avoid the use of radial grafting. Why? Because the patient may need future dialysis. So for that, this vessel will be very, very useful for AV fistulas. So in such conditions, we try to avoid the radial graft. And the point again MCQ, we have to administer oral calcium channel blocker like diltiazem for 1 year after radial artery grafting, because this vessel will be very prone to spasm because of the thick muscular thing. Again, regarding the bilateral internal mammary harvesting, we try to use skeletonization technique rather than a pedicle technique. Again, why skeletonization? To avoid future wound infection or chest infection. And regarding the inotrope, again, in the previous edition, there was no any major update about the inotrope, but this new edition has been clearly given what are all the drugs that will be very helpful in CABG. And for MCQ point of view, I have highlighted few points. Even though dopamine is a very good drug, but it may aggravate the shock. Suppose a patient coming with coronary artery disease and the patient is in shock, we should try to avoid dopamine. Okay, we can try to prefer epinephrine. And the patient having severe vasoplegia after CABG. So what is a vasoplegia? In spite of patient having adequate cardiac output, a patient having hypotension. So that situation signifies vasoplegia. And in such conditions, the best drug will be phenylephrine. It is a pure alpha agonist. And you should also note which drug is a pure beta agonist. It is isoproterenol. And you have to know drug, the milrinone. Milrinone is a phosphodiesterase 3 inhibitor. It is a beautiful drug in refractory heart failure and in low cardiac output states. And nitroprusside, it is very useful in hypertensive emergencies. And you should also know amiodarone. That's a class, amiodarone class is a class 3 antiarrhythmic drug. It is very helpful to treat atrial and ventricular arrhythmias. And lidocaine is a class 1B antiarrhythmic drug. Again, the usage will be ventricular arrhythmias. Likewise, you should know the importance of each and every drug for a CABG patient. The next update being the usage of antiplatelet therapy. So aspirin, so when to give? So it should be given within 6 hours after CABG. Okay, the dose is like this. And in some patients where we are not using mammary artery, we have used venous graft only. So in such conditions, to maintain the saphenous vein graft patency, we may need to use dual antiplatelets. And so these are all the updates for coronary artery disease. And the coming updates are very new because the heart transplantation, lung transplantation, it is very new. Last year, Sabiston, there was no any update, no any points about the transplantation regarding the heart and lung. And the first transplant has been done by Christian Bernard in 1967. And the dramatic improvement after heart transplantation has been clearly evident after the advent of endomyocardial biopsy. It is nothing but after the heart transplantation in the follow-up period, say 6 months or 1 year, to identify the early graft rejection. Here, what is the graft? It is the heart, what the patient received. To avoid the early graft rejection, the endomyocardial biopsy will be very, very helpful to for early identification of the graft rejection. And this has been first came into use in 1973, and the use of the wonder drug cyclosporin in the 1980. So from the 1980 only, the success rate of heart transplantation is keep on good because with the advent of cyclosporin. And regarding the update, what is the indication of heart transplantation? Indication, the first and foremost being advanced heart failure, and it is given in your book stage D. Stage D, the refractory heart failure. So this is again MCQ point of view. The common causes being ischemic cardiomyopathy, dilated cardiomyopathy, congenital heart disease that we'll be discussing in our online and offline classes, and myocarditis. Then regarding donor selection and preservation. So the donor being usually brain dead, less than 60 years will be ideal, and there should not be any structural heart disease in the donor heart. And importantly, the patient should have a good, adequate ventricular function. And regarding the organ preservation, again MCQ point of view, the cold storage time will be 4 to 6 hours. Okay, 4 to 6 hours will be safe after arresting the heart by giving cardioplegia. And there are new transmetic systems that has been improved to further extend the viability of the heart. So for MCQ, what is the cold storage time? It is 4 to 6 hours for heart procurement. And regarding the next update, immunosuppression. So after heart transplantation, so what are the immunosuppressants we need to give? That is very important. So during surgery, during the induction of anesthesia, we should give high dose steroid, and sometimes anti-thymocyte globulin should be given during the surgery. And the maintenance period, we have to give cyclosporin or tacrolimus along with mycophenolate or azathioprine and a tapering dose of steroids. So these are all the immunosuppressant drugs. And the rejection, coming to the rejection, it may be cellular rejection or antibody mediated rejection. And this we can able to identify by doing endomyocardial biopsy in the first year. And recently I can able to see many image-based questions has been keep on asking in your examination. So if question asked like this, so this image has been given in your new book. This is after heart procurement from the donor heart, okay, for heart transplantation. So this is a clear-cut example of orthotopic transplantation. So we will be fixing the heart at the same site. Okay. Regarding the outcome, so what is the success rate after heart transplantation? 1 year survival is 90%. The median survival is 12 years. And with the advent of immunosuppressant, the quality of life has been significantly improved. And coming to the pediatric and adult, pediatric outcomes are similar or slightly better than the adult heart transplantation. So this has been given in your new book. And in some individuals where the patient with uh, lung disease also. So we can combine the heart and lung transplantation also. And we can also do heart and kidney transplantation. And we can also do heart and liver transplantation at the same time. And again, MCQ point of view, a few points about xenotransplantation, but it is still experimental, but promising with porcine hearts. Already a porcine heart has been transplanted on a human, showing a promising result. But after a few months, the patient died because of viral pneumonia. So again, it is under experimental. Again, porcine heart still appears to be superior among the xenotransplantation. Next, a few updates about lung transplantation. The indications being end-stage respiratory disease and response due to medical therapy. The common causes being COPD, again MCQ point of view, followed by interstitial lung disease, bronchiectasis, cystic fibrosis, then pulmonary arterial hypertension, being these are all the indications for lung transplantation. And traditionally, again, cold storage time will be here there is leverage because lung tolerates ischemia greater than the heart. So 68 hours at the cold storage time being. And we can also extend the viability with the use of transmedic system. So we can do a single lung transplantation or a bilateral transplantation. The incision what we are using for lung, this thing is clamshell incision, right? So the indications being cystic fibrosis, bronchiectasis, and pulmonary arterial hypertension. So what are the complications after lung transplantation? The primary graft dysfunction, the PGD, acute lung injury post-transplant, then infection. If you talk about lung transplantation, infection will be the culprit showing giving major morbidity, and lifelong surveillance will be very important. And the acute rejection may be due to cellular or antibody mediated as discussed for heart transplantation. And the chronic rejection, again MCQ point of view, the chronic lung rejection is maybe due to bronchiolitis obliterans syndrome, BOS, and restrictive allograft syndrome. So these are the 2 points that has been given on your new Sabiston. And coming to the outcomes, definitely the lung transplantation survival will be lesser than the heart transplantation because primarily due to infection and the graft dysfunction. And the best among the lung transplantation, the best results will be good after cystic fibrosis individual, and a very poorer response in those patients with interstitial lung disease. And these are all the new updates about the pulmonary embolism. Again, this topic has been newly added in this Sabiston 22nd edition. And regarding the pathology and pathogenesis, coming to the source of pulmonary embolism, as you all know, it is a deep vein thrombosis in the lower limbs or pelvis. The embolus lodges in the pulmonary arteries. What are the consequences? Because of the lodgement of the pulmonary artery by emboli, there will be increased pulmonary vascular resistance. That leads to right ventricular strain or right ventricular failure, and that compresses. Once the RV failed, it distends. So it distends the nearby chamber, that is the left ventricle. So that reduces the LV filling, and that leads to shock or death. So that is the consequences. This is a sequelae of a pulmonary embolism. And this is the table that has been given in your book. The surgical classification of a pulmonary embolism appreciate depending upon the level of occlusion. It has been classified into level 1, level 2, and level 4. right? Because you can able to see the level 1, the chronic thromboembolic disease burden will be in the main pulmonary artery. And if you see the level 3, it will be at the subsegmental level. Level 3 is segmental level and level 4 is subsegmental level. So these are all the pulmonary artery branches, and this is the main pulmonary artery. Clear? And these are all the specimens which after pulmonary embolectomy, the specimen will be appearing like this. Again, image-based question. This picture has been given in new edition book. So this you can able to appreciate the pulmonary artery. This is the pulmonary artery, and this is the aorta, and this is the descending thoracic aorta. So in this picture, you can able to appreciate the thrombus sitting in the pulmonary artery, right pulmonary artery. Okay. So likewise, you can also able to identify a few image-based questions in your new book. Next update. So what is the presentation after an embolism? So commonest presentation being dyspnea, and the patient will have chest pain, and the syncope because of hypoxia, and the hemoptysis because of pulmonary infarction. So what are all the signs we can able to appreciate? They are tachycardia, tachypnea, hypoxemia, and the hypotension if the embolism is massive. Again, the gold standard investigation for chronic pulmonary embolism being CT pulmonary angiography. There is no doubt that we couldn't able to do angiography that because of the patient having a CKD, we couldn't able to use the dye. We can use ventilation perfusion scan. And we have to utilize the D-dimer for exclusion in low risk individuals. And the echo will be definitely showing whether the patient is having orbital dysfunction or not. And has been given in your new book that are the clinical scores for pulmonary embolism, right? Wells, Geneva, and PESI. So kindly go through this scoring system also in the pulmonary embolism. And coming to the treatment of acute pulmonary embolism, the first choice being anticoagulation, unfractionated heparin, low molecular weight, and directly acting anticoagulants. These are all the mainstay. And we can also do a thrombolysis in acute condition. And we can also consider the catheter-directed therapies for thrombolysis. Surgery will be rarely indicated. If at all indicated, we have to do a pulmonary embolectomy, and there is always a role for ECMO as a bridge in a refractory shock. The patient present with refractory shock, we can consider ECMO, and the role of IVC filter will be always there. The patient is having a significant deep vein thrombosis, because addressing the thrombus in the pulmonary artery alone won't cure, because there may be the possibility of showers from the lower limb. So we have to consider the IVC filter to prevent the showering of the embolus from the lower limb. And the next update about the chronic pulmonary embolism is popularly called as CTEPH, and it occurs because of the organized thrombus adherent to the pulmonary wall that causes vascular remodeling, and that leads to progressive pulmonary artery hypertension and RV failure. So what is the procedure? The name is pulmonary thromboendarterectomy, and it is curative in operable disease. And coming to the medical therapy, the patient should need to take lifelong anticoagulation, and there are pulmonary vasodilators like riociguat and phosphodiesterase 5 inhibitors like sildenafil, and we have to prescribe endothelin antagonists like bosentan like that in inoperable or persistent pulmonary artery hypertension. And there are updates on ECMO. Again, this year, the ECMO has been newly added in your book, and I'm going to discuss about a few updates that has been given in your book. So if you look at this chest X-ray, again, the MCQ can be asked. So what is the device in the heart? So this is the heart, this is the left ventricle. You can able to appreciate a bigger catheter in the left ventricle. It is called as impella. It is called as impella, and it is the device which is used for left ventricular decompression in cardiac failure. Okay. And ECMO. ECMO provides a temporary mechanical support for a severe cardiac and respiratory failure unresponsive to the conventional therapy. The configurations being VA ECMO is called as veno-arterial ECMO, and you can able to appreciate here VA ECMO and VV ECMO. So what is VA ECMO? VA ECMO is nothing but veno-arterial ECMO. We are taking blood from the vein, getting oxygenated in the ECMO device, and the oxygenated blood will be delivered back into the artery. This is called as VA ECMO. It will be very useful for giving a cardiac support in severe cardiac failure. And what is VV ECMO? We are taking blood from the jugular vein and giving to the femoral vein, or vice versa, for giving adequate respiratory support in respiratory failure. And this VV ECMO plays a major role in COVID illness. And we can also consider VAV ECMO as a hybrid method for a combined and dynamic support. So techniques and cannulation. So VA ECMO, it is nothing but femoral vein to femoral artery, or the right atrium to aorta. So peripheral or central ECMO according to the types of cannulation. And as I told, VV ECMO, internal jugular plus femoral vein, right? So this is called as VV ECMO. This is called as VA ECMO. VA ECMO for cardiac failure, VV ECMO for respiratory failure. So respiratory failure and severe ARDS, refractory hypercapnia with acidosis, it will be very, very helpful. Again, it is used as a bridge to recovery, and for lung transplantation, right? It will be very, very helpful. And during weaning, it improve gas exchange, lung compliance will be improved, right? So these are all the points that has been given in your new book. And regarding the cardiac failure, VA ECMO, as I told, will be very, very helpful. And indications being cardiogenic shock, the post-coronary shock, myocarditis, pulmonary embolism with collapse, and again, it's a bridge to recovery. And as a LVAD or transplant, this always will be very, very helpful. What are the issues for after using the VA ECMO? It increases the afterload and the need for LV decompression. It means that during an ECMO, there is a possibility of increase in afterload. So in such conditions, we have to use an IABP or we have to use an impeller. Again, this is one of the issue of using an ECMO for a long period of time. And again, this book has been given a special entity which has been given in our standard book and has been given in your new Sabiston. This is called as Harlequin syndrome. So what is Harlequin syndrome? There is a differential hypoxemia in upper body. So how? And this next update being the Harlequin syndrome. It is also called as North-South syndrome. It is again MCQ point of view, it is seen in peripheral VA ECMO. So it occurs when lungs are not oxygenating well, and the native left ventricle ejects deoxygenated blood into the aorta. So while patient is on ECMO, suppose the patient's native lung is not functioning properly, and because of not functioning properly, the lung couldn't able to deliver oxygenated blood into the left ventricle, so that the upper half of the body, so blood is pumping, no? So the upper half of the body may receive the deoxygenated blood because of the poor lung oxygenation. Whereas the ECMO gives oxygenated blood at the peripheral level. So upper half of the body perfused with hypoxemic blood, the lower half of our body will be well oxygenated by the ECMO blood. So how can we convert this, once the patient develops this Harlequin syndrome, we have to convert the peripheral ECMO into central VA ECMO. So that is a solution to avoid this complication. So again, this picture has been given on your book. So you can able to appreciate the deoxygenated blood ejecting from the left ventricle enters the upper half of the body through the and with the help of peripheral VA, we have to give unfractionated heparin, and we have to maintain an ACT of 180 to 220 seconds. So again, this is very important. And special situations, the use of ECMO, it has been proven during COVID-19, ECMO survival percentage was up to 40 to 50%, because many patients have been succumbed to respiratory failure. And as a bridge to transplantation, again, ECMO having its own role. And coming to the pediatric and neonate, the use of ECMO will be very helpful in congenital diaphragmatic hernia and meconium aspiration syndrome. So these are all the non-cardiac benefits of ECMO. And regarding the outcome survival, the VV ECMO 60% survival in severe ARDS, and with the VA ECMO, 40% survival in cardiogenic shock. So these data has been clearly given in your new Sabiston. So that's all, guys. These are all the updates in your new Sabiston. So all the very best and do well, guys. We'll be see you all soon in doctor tutorials and our next classes. Take care. Bye bye.